to you, and welcome to this episode of Functional Medicine for Real World Impact. Today, we're going to be talking about reverse T3, a myth riddled and certainly often argued biomarker of thyroid function. Reverse T3 is actually one of those topics where uh, advocates of both more of a purely conventional medicine or more of a purely functional medicine approach often oversimplify this important thyroid physiology, but in opposite directions. Reverse T3 is undoubtedly one of the most misunderstood markers in thyroid physiology. In conventional medicine, it is often dismissed as being clinically meaningless. But in functional medicine, it's often treated as a villain, the most important thing to try to wipe out. And as usual, the truth, the most honed clinical approach usually lies somewhere in between those two extremes. In this episode, we're going to be separating myth from physiology and exploring what reverse T3 actually is and what it's telling us about a unique patient's body. That understanding can change your clinical response. Today, I'm going to be debunking 5 myths about reverse T3, and the clinical truths that they reveal can strengthen your clinical capability right away. But first, let's start with a quick thyroid physiology review to make sure we're all starting from the same place. We remember that the HPATG axis enables the body to have this interactive dynamic connection between the brain, specifically the hypothalamus and the pituitary. That's the H and the P of the HPATG axis, coordinating with a number of different glands downstream in order to create an orchestrated endocrine response in our bodies. Regarding thyroid hormones specifically, the hypothalamus is releasing a hormone called TRH, or thyroid releasing hormone, which then tells our pituitary gland to produce and release TSH, or thyroid stimulating hormone. TSH is not a thyroid hormone, it's a brain hormone. And it is going to tell our thyroid gland to produce thyroid hormone, predominantly T4 thyroid hormone. It's the only place in the body T4 thyroid hormone is produced. But the thyroid gland itself also produces a significant amount of T3. And while that local T3 goes to serve thyroid hormone needs, the lion's share of that T4 and that T3 that are made in the thyroid gland are going throughout the body to be taken up in a very controlled way by our cells. It's important to realize that by and large, our cells throughout the body, whether it's a cell in our liver, a cell in our kidneys, a cell in our brain, or in our right quadricep muscle, those tissues, those cells are predominantly taking up T4 thyroid hormone and then deciding intracellularly how much of that hormone it wants to convert to T3 for its primary needs. T4 thyroid hormone has almost no or negligible affinity for nuclear thyroid hormone receptors. So it's actually the T3 thyroid hormone that is our metabolic accelerator pedal, if you will, right? It's through a number of different pathways, it is determining our basal metabolic rate in that cell. And it makes perfect sense that tissues are going to want to control their own metabolic fueling, depending on whether it's a tissue that needs to be strongly activated in the moment to help us to thrive in the current environment, or perhaps it's a tissue that needs to experience less oxidative stress and damage, part of the natural waste product, if you will, of our metabolism, right? Metabolism is important. It makes us vital and energetic and able to do a lot of things with finesse and fitness. But Metabolic activity creates free radicals. It creates oxidative stress. And so we don't want any tissue to have excessive amounts of metabolic activity because it may not be a good match for what that tissue is wrestling with at the time. Now, intracellularly, our cells are bringing on T4 and to a lesser degree T3 thyroid hormone. And then each cell has its own enzymes, deiodinase enzymes, that are determining in that moment what to do with all of that T4 and all of that T3. Does it want to increase our metabolic fire and take a lot of that T4 and turn it into T3 and activate more metabolic activity? Or does the wisdom of the cell say that we actually want to turn down the volume level, turn down the heat, the metabolic pace in our environment? And so we want to deactivate some of that T4. And this is what reverse T3 is. Reverse T3 is an inactive form of T3 thyroid hormone that essentially allows metabolic conservation. And so we have to, before we can really explore these five myths, we all just need to remember that the body's individual tissues are making independent decisions about the fate of the T4 thyroid hormone that comes into its environment. And that decision is not random, it is a reflection of the physiological environment that the body, and more immediately, that tissue believes it's living in. So let's get to the myths. The first of these is a common myth in functional medicine clinical communities that reverse T3 is bad. Not true. The reality is that reverse T3 is a critical part of normal thyroid physiology. Every healthy person is continuously making some level of reverse T3. It's simply one of the normal fates of T4 thyroid hormone, and it's being turned into reverse T3 via the D3 deiodinase enzyme. And the body is constantly doing this as a check and balance in order to even a cell that wants to have a lot of metabolic fuel, the pace of T4 coming into the cell is very likely not going to match ideally what the cell wants to do for its own metabolic needs. And so the D3 enzyme is always active to at least some small degree in terms of checks and balances, making some level of reverse T3. So, while we want to look in a full thyroid panel to see if reverse T3 is elevated, instead of seeing that as a villain and saying, okay, how do we wipe that out? How do we stop it? The question we want to be asking upstream instead is, if it is indeed elevated, what is happening in the environment of this tissue or in the environment of the body that is causing some cautionary restraint on our metabolism? And indeed, there can be lots of reasons for that. And I think it's important that we understand that the drivers and the reasons are going to vary by individual, but we can take elevated reverse T3 as an important clinical cue and clue. Certainly, if individuals are taking too much thyroid hormone medication, in particular, too much T4, levothyroxine, it is common for the body to countermand that excessive metabolic fuel by converting a lot of it into reverse T3. This can be because of a thyroid medication. It can also be because of a disease such as hyperthyroidism, like Graves' disease, where the body, in its own wisdom, is deactivating a lot of that excessive thyroid hormone. It can be a sign of a body in a state of elevated inflammation, maybe because of a raging infection, high viral load. a highly toxic state, maybe a recent injury or trauma, perhaps on the other side of surgery. Again, situations in which it would make sense that because the body is healing, we don't want to create a lot of metabolic fuel. We want to allow a more parasympathetic state for higher antioxidant support in order to facilitate an environment for healing. It's also true that in some individuals, a chronic stress state, mental, emotional, physiological stress or trauma, can be a warning flag for our deiodinase wisdom to not run so hot, not run so metabolically turned up or amped up. It's also true that certain medications, not very many, but certain medications like amiodarone or other medications that present with high iodine content might serve as a warning flag for the body to purposefully start making more reverse T3. And so, reverse T3 is not bad. It's important metabolic oversight. And instead of being villainized, we want to think about what is it telling us so that we can engage more effectively with our clinical approach. Myth number two is that reverse T3 itself can make someone hypothyroid. And that is not necessarily true at all. It's another common myth. The reality is that reverse T3 is inactive thyroid hormone, and it is a marker of the body choosing to deactivate a significant amount of T4 thyroid hormone. And the reverse T3 itself does not um, hamper our metabolic state. Reverse T3 does not compete directly with T3. There's other myths about that as well. But I encourage you to think about reverse T3 as being a footprint, a clue about the physiology deciding to divert T4 away from T3 production. And this is where we can look at a unique individual's drivers. Again, is there inflammation? What's the status of their liver health? What's the status of their nutrition? Do we want to take a look at maybe some imbalances in their thyroid medication? What is their current state of stress? And how can we help an individual to change their behavior so that cellular wisdom sees over time appropriately that it is a safer environment in which to be more metabolically active. But the high reverse T3 itself, all on its own, is not causing hypothyroid symptoms. It's simply a marker of T4 deactivation. It's entirely possible that a person simply has excessive T4. And so their reverse T3 might be elevated, but on the other hand, their free T3, right? Their actual metabolic upregulating hormone may also be quite high. The reverse T3 on its own is not promoting a hypothyroid state when it's elevated. Okay. Myth number three has to do with stress. There are many practitioners, especially in the functional medicine world, who believe that reverse T3 is always a sensitive and specific marker for high stress states. I've even heard practitioners say that reverse T3 is a marker of a sympathetic dominant nervous system mode. Not necessarily is the reality. It's actually an important misconception. There are individuals who are undergoing high stress states and a true sympathetic dominant nervous system mode that's creating a lot of imbalanced stress physiology. But their reverse T3 may not be elevated at all. In fact, their reverse T3 might actually be low. And this is what you're going to see quite commonly, by the way, in true hypothyroid states, because if the supply of T4 is already on the low side, then there's simply going to be insufficient substrate to generate large amounts of reverse T3. Right? We can only make reverse T3 to the extent that we have sufficient and abundant T4 in order to do that. The D3 deiodinase enzyme is one of three powerful intracellular deiodinases. D1 and D2 are generally activating deiodinases, right? They are making T3 thyroid hormone. And the difference between D1 and D2 is physiology you can learn. We certainly teach the detailed nuances of that at SAFM. But D1, the D1 enzyme is by and large hanging out by the cell membrane, and it's taking a lot of T4 and converting it into T3, not only for that cell to use, but also for sharing a lot of that T3 back out into systemic circulation. So, the D1 is synthesizing for local use, but also sharing. The D2 deiodinase tends to hang out further into the intracellular environment and is by and large generating T4 for T3 to T3 for only local use. And this is the most active enzyme, by the way, in the brain. For example, in the pituitary, that's determining our supply of TSH. And that internal conversion can actually be quite different from other tissue in the body. And it's a topic for another podcast of why TSH is not at all a sufficient marker of systemic thyroid hormone sufficiency on its own. Another common myth, but another topic for another day. But D1 and D2 are largely activating deiodinases. D3 is best thought of as a deactivating deiodinase, right? D1 and D2 are trying to turn up the volume, turn up the temperature on our metabolic fire. But D3 is generally trying to turn down the volume, turn down the temperature or the possible oxidative risk on our metabolism. And so D3 as an enzyme is not only deactivating our T4 by turning it into reverse T3, but when D3 is amped up, it also is going to be deactivating our T3 by turning it into an inactive form of T2. So it has a couple of different modes via which it can turn down our metabolic fire. But again, D3 can only modulate either of those things to the extent that it has substrate to work with. So if an individual already has suboptimal levels of T4, even a strong stress state or a highly active D3 enzyme doesn't have a lot to work with. And so you're not going to see necessarily elevated levels of reverse T3 in all cases of chronic stress physiology. Again, whether that's mental emotional stress or whether it's more of a physiological, inflammatory, toxic type of stress. And so this is speaks to the myth that a lot of practitioners expect and assume that reverse T3 will be elevated in states of chronic stress, and that is not necessarily the case. The fourth myth I already mentioned briefly. It's probably the most prevalent or debilitating myth in thyroid physiology, especially in functional medicine. And this is the notion that reverse T3 is not only deactivating T4, but reverse T3, once we make it, is somehow going to go fit in a thyroid hormone receptor and occupy a spot and keep T3 thyroid hormone from being able to activate a receptor. And the reality is, despite the frequency of the myth, that there is little to no clinically meaningful evidence of that at all. The reverse T3 hormone actually has very, very weak affinity for our thyroid hormone receptor, especially in comparison to T3. So it is not actually serving as a blocker of T3 activity. And this myth is actually what contributes to many practitioners seeing reverse T3 as not just annoying or a red flag, but being a metabolic villain. Instead, again, I encourage you to think about reverse T3 coming from the D3 deiodinase activity as the enzyme in its wisdom responding to the environment. And then our opportunity is to say, why is it doing that? What am I missing in the fuller clinical picture that needs to be addressed so that the body can feel safer and wiser in having more metabolic fire and then can do it on its own? This is an important myth to dispel because it's taken a centerpiece in a lot of functional thyroid physiology for a long time. Now, the fifth myth I want to address today has to do with the lab marker itself and a common misstep in a lot of different functionally informed practices, which is treating the labs, right? That we want to simply try to normalize the lab markers rather than using it as a red flag and focusing on going upstream and understanding the larger story of what is at play in a unique body right now. And so, reverse T3 is an important part of the story that the lab markers are telling us. But as I mentioned earlier, we at SAFM recommend highly that we check a full thyroid panel, including TSH or thyroid stimulating hormones, so we can understand the brain's perspective. From the brain's viewpoint, what is the sufficiency of thyroid hormone in the body right now? This is the hypothalamus and also the pituitary responding to its own local ability to convert T4 to T3 inside the cells, and making the assumption that if the brain cell is satisfied, then all the rest of the body cells must be as well. And as I've already explained, that is very frequently, by the way, not true. Sometimes you may see optimal levels of TSH, but if you were to run a full panel, and I've seen lots of practitioners shocked by this, just how often T4 and T3 levels run at the same time, coincident with a perfect TSH. T4 and T3 thyroid hormone might be woefully suboptimal or even clinically low. Sometimes both of them are clinically low. And this speaks to the fact that the TSH is an important marker to run, but it's only telling you about the brain's perspective of systemic thyroid hormone sufficiency. We also want to check T4. We recommend checking free T4 and free T3 because that's the amount of thyroid hormone that is unbound by binding globulins such as thyroxine binding globulin, TBG, because hormones have to be unbound in order to be taken up by cells throughout the body and used for metabolic purposes, whether it's activated or deactivated. You may still want to check total T4 and or total T3 at least once so you can really understand in a unique person whether elevated levels of binding globulin might be part of their hypothyroid presentation or their hyperthyroid presentation. But on an ongoing monitoring basis, free T4 and free T3 usually need to be checked and need to be checked together. We do recommend checking reverse T3 so we can understand the body's wisdom in driving deactivation of thyroid hormone, right? What does the body believe is the safest thing to do in the environment in which it finds itself right now? And then we also recommend checking both. For example, in cases suspicious for hypothyroidism, we want to check both TPO and TG thyroid antibodies, checking both thyroid peroxidase autoantibody and also thyroglobulin autoantibody. Many practitioners have the habit of checking only one or the other because they assume that if there's an autoimmune dynamic at play, a prominent one in the body, both will be elevated. So all you have to check is one. And that is also not true. In fact, I would say more often than not, it's only one or the other that is elevated. And if you happen to check the one that's not elevated in a case of autoimmune thyroiditis, then we're missing a massively important clinical clue to help us to respond appropriately. But reverse T3 is just part of the story. It's not a standalone decision maker. We want to be looking at a full thyroid panel, especially at our initial investigation of a likely hypothyroid or a likely hyperthyroid state. Just like you might or might not see elevated levels of reverse T3 in a case of hypothyroidism, you may or may not see an elevated case or level of reverse T3 in hyperthyroidism, like Graves' disease. But again, you're going to see that elevation and need to respond to it. As I shared earlier, there's lots of different reasons why that might be at play. A couple of everyday reasons that I didn't mention earlier include things like excessive fasting or excessive calorie restriction for a unique individual. This may bring us back into the importance of customizing the protocol, customizing the clinical approach for a unique individual. And staying away from, the right duration of fasting is this amount, or the right amount of calories taken in for a certain weight loss goal is this amount. The body is more complex than that. And if we're going to do our most effective clinical work, we have to customize our clinical interventions and use data like reverse T3 as a wake up call to cast a broad net and taking a look at what we might be missing. Elevated reverse T3 likely means something different in that same value between, say, one woman and another woman who are presenting with hypothyroid symptoms. So, reverse T3 helps answer how the thyroid physiology is responding, but it also helps us to take the cue and the clue and look upstream. For sure, simply giving more thyroid hormone of the T4 variety is very likely going to be completely counterproductive and only going to serve to upregulate reverse T3 further, because it's not resolving the body's caution that there's a risk of having more metabolic fire in this unique body at this particular time, right? So I hope these myths and again, the truths that they reveal are enlightening for you and give you some clinical insights that you can use in your practice right away. Again, reverse T3 is not an enemy. It's actually a really valuable marker, an important metabolic oversight, right? D3 deactivation, countering that powerful D1 and D2 proactivation of thyroid hormone. The body overall, but also the specific cells are constantly in their wisdom using a balance in order to try and help each tissue to thrive in the body in which it's living right now. So we want to shift the conversation from how do I reverse or suppress reverse T3 to questioning and exploring why has the body decided that slowing metabolism is the safest strategy for this unique person today. That helps you as a practitioner to go from protocol based thinking to true systems optimization based thinking. Besides, other than reverse T3 being something you should ignore or something that is the end all be all of thyroid villains, we want to take a smarter approach, that sweet spot in the middle, and understanding that reverse T3 is an adaptive biomarker. Whose interpretation always depends on context and this unique person that you're supporting. I thank you so much for joining us today and look forward to being with you in our next episode of Functional Medicine for Real World Impact. Have a great day.